Bismillah ar-Rahman ar-Rahim. Ladies and gentlemen, first of all, thank you for coming after this nice coffee break. And I hope everybody is fresh now. This session is going to be about prostate embolization. And I like to refer it as the masculine part of the interventional radiology. First of all, I have the pleasure to present Dr. Mohammad AlMoalqel. Dr. Mohammad AlMoalqel is a consultant interventional radiologist from the National Guard Hospital in Riyadh in Saudi Arabia. Dr. AlMoalqel started his practice in Saudi Arabia after returning from his training in Canada. And actually, he's one of the very few first ones who started prostate artery embolization in Saudi Arabia. Dr. AlMoalqel, please.
Thank you, Dr. Ashur. It's my pleasure to be here and to give the talk about the prostate anatomy and the arterial supply of the prostate gland. Thank you for the organizing committee. Thank you, Dr. Shamri. So, what information you need to know about prostate before prostate embolization? The most important information are the arterial anatomy, arterial supply, angiographic pictures. Prostate gland, as you all know, it's a small pyramid organ located in the base of the apex of the urinary bladder. It weighs approximately 20 grams, size 3-4-2 centimeter. It has 4 zones: peripheral zone, which constitute more than 70%, central zone in 25%, transitional zone in 5 to 10%, and anterior fibromuscular, which has no glands. As you all know, prostate CA mainly it happens more than 70% in the peripheral zone. BBH, it's in transitional zone. Chronic prostatitis only affecting mainly also the peripheral zone. Just a few slides on the distribution of those zones, as it's important if you are doing endorectal ultrasound examination. Why the arterial anatomy is very important? Because of the embolization, which is been published long time ago, even before 2003, only published at that time just to control bleeding, either after urological malignancy or post-surgical. Being published 2003, 2008, and then Dumerit published the first case in 2000, where he shows that there is probably interesting information if you embolize the prostatic artery in cases of BBH. Dr. Carnavali, who is the one who published a series of cases in 2010, and then Dr. Pisco and his group in 2011. The arterial anatomy is very complex, so you have to know in details the pelvic arterial anatomy. It's very complex in a way. There are the internal iliac arteries divided into anterior and posterior division, and the anterior branches has its own supply, own branches. Posterior also has its own branches. Many names, many different terminology, but the most important is the anterior and the posterior trunk. The anterior trunk mainly is the prostatic artery comes mainly from the inferior vesical artery, which is usually the second branch if you goes from cranial aspect. The inferior vesical artery gives the prostatic branches, which can divide also into the different branches, like a capsular branch, lateral branch, and even the urethral branches. The inferior vesical artery, which is the main supply of the prostatic artery, comes usually off from this location. What do we call it? The anterior gluteopedonal trunk. The easiest way probably to remember is what's been published and mentioned by Dr. Carnavali is the Profizu name. Profizu stands for, if you start counting from posterior. PR is the pudendal, interpudendal artery. The R is the middle rectal artery. And then O is the obturator, which is the inverted Y. And then you start to have which is the most important artery to supply the prostatic artery, is the VI. It's the inferior vesical artery, which is usually tortuous. And then the superior vesical artery, which is very important artery to know and not to embolize, to avoid embolizing it. And O is oblique view. So prophesio is, I found it very easy for the guys who started or want to start the prostatic artery embolization. Few tricks also before starting this practice. CT angiography with MEP and VR multiple reformation. CT angio is important in many aspects. First, you remember those patients are very old. They are atherosclerotic. You might face occlusion. You might face tortuous vessels. You might face even internal iliac artery occlusion. So I think a CT angiography in multiple planes can give you tremendous information before prostatic artery embolization. During angio, the best view to identify the inferior vesical artery is the 25 to 55 degree ipsilateral oblique with 10 to 20 degree of caudal angulation. Foley catheter, also another trick also a patient has to have before the angioembolization. And I'm going to talk in details in a few slides. This slide's from Dr. Carnavale, which shows that the inferior vesical artery is the second branch after the superior vesical artery, if you are counting above. And don't forget the prophesio, which is also very valuable information in ipsilateral oblique. Remember, the prostatic arteries can come off from different arteries, almost every single artery in the pelvic architecture. Mainly is the internal pudendal artery. It can arise also from the superior vesical artery. It can be from the, as mentioned, gluteopudendal trunk. It could be also from other arteries. Not only where the prostatic artery comes off, the type of anastomosis for the operator has to understand it, that the prostatic artery can anastomose with a different artery, including the internal pudendal artery, so you have to be careful not to embolize. Or before embolizing, you have to embolize the shunt or the anastomosis by coil, the anastomosis to contralateral prostatic artery, rectal or vesical arteries. As I mentioned, CT angiography is a good tool to start with to prepare yourself before doing the prostatic artery embolization. A correlation between CT angio and conventional angio, and it shows the prostatic artery arises from the inferior vesical artery. Another patient which shows, okay, prostatic artery arises from the inferior vesical artery, but there is another prostatic artery, which is the accessory, which can be seen also in approximately 2% of the cases. And in these cases, you have to embolize. This patient has superselection of the right inferior vesical artery and then the prostatic artery. Injection of contrast shows communication with the intraprostatic artery to the other side. So, as mentioned, the cone beam CT angio, and it's very valuable tool during the embolization. This patient was not difficult to superselect the inferior vesical artery and then injection of contrast. If you do a CT angio while the patient is lying down before embolization, this is the information that you want to, or the image that you want to see, that there is homogeneous uptake of contrast in the half of the prostatic gland. in the axial images and the coronal images. At the same time, you have to be careful. Another patient who had what thought to be inferior vesical artery on the right side, prostatic branches, although there is no supply of the prostatic gland, injection of contrast, and then CT beam shows that this is not the inferior vesical artery. In fact, a matter of fact, this is inferior rectal artery, and there is a contrast seen in the rectum. Another difficult patient also, superselection on the contralateral side, injection of contrast. Probably it was thought that this is the prostate. CT angio shows that this is not the inferior vesical artery. This is, a matter of fact, this the superior vesical artery with a capsular branch, and there is supply of the wall. This is, again, a vessel that you have to avoid embolizing it. Otherwise, the patient is going to have necrosis, probably focal necrosis. Another patient who has two arteries supplying the right side, angio, and then CT beam shows that the contrast only seen in the central zone, not in the peripheral zone. It gives you an indication that there must be another artery. And in matter of fact, yeah, there is another artery being super selected, injection of contrast, and it's almost like a homogeneous uptake of the contrast in the half of the prostate. So it's very careful to study the CT angio prior to the embolization. So in conclusion, detailed angiographic arterial prostate supply are mandatory to be known by the interventionalist before and during PAA. I find CT angio before, ipsilateral view, Foley catheter, and cone beam CT all are useful during the prostatic artery embolization. Thank you.